You are listening to Breaking the Waves, conversations about the Dutch pandemic. My name is Matt Cornell, and this is a English language podcast that takes a critical look at Dutch coronavirus policy. Today, my guest is Marino van Zelst. Marino van Zelst is currently a final year PhD candidate at the Department of Organization Studies at Tilburg University. His research interests concern how decision makers evaluate and act upon performance signals. Marino is actively involved in the professional community. He participates in knowledge exchange sessions with stakeholders and is a member of the expert panel for the COVID-19 dashboard and performance indicators for the Dutch Department of Health. Moreover, Marino is a member of the COVID-19 Red Team in the Netherlands, which provides unsolicited advice to the Cabinet and Parliament on coronavirus policy from a multidisciplinary behavioral perspective. Our conversation was recorded on June 24th of 2021. So Marino, thank you very much for joining me today on Breaking the Waves. And I just thought to get started for listeners who may not be familiar with what it is that you do, could you tell us a little bit about how you got involved with the Red Team and what you do for the Red Team?
Yeah, well, thanks for the invitation. Obviously, that's the first thing to mention. So how this all got started is I started analyzing excess mortality data during the first wave. So that's April and May 2020, and then posting these analyses on Twitter. And then in June, I think the RIVM, the National Public Health Institute, announced that they would no longer do daily updates on the website and on social media, but they announced they would publish the open data on some website. I'm pretty okay with programming, and I just wanted to know myself. So I started programming in such a way that I could automatically extract the numbers every day with the open data, and also started publishing it on Twitter. And apparently a lot of people wanted to know those numbers daily. So then I started together with Edwin Veldhuizen, who is also in the Red Team, publishing the numbers, and I focused more on the national statistics, and Edwin focused on the more municipal or regional statistics. And we've been doing that since basically the 1st of July 2020. So well, basically when this is posted, we'll do this for a year every day. And then at some point we actually found some mistakes in the numbers. So the official numbers did not show the corrections that were taking place. So sometimes double entries ended up in the data, for example. And we figured out a way to extract those. That led to me ending up in a newspaper with like a short article on these data errors. And apparently that caught the attention of my now colleagues in the Red Team. So then I got invited by Amrish and the rest of the then original members of the Red Team to join because they were looking for somebody who was thinking more strategy-like, social science-like, and who's good with numbers. And that's kind of my profile, I would say. So within the Red Team, the unofficial name is Chief of Numbers. So I basically work with a lot of other people who also work with the data numbers. We also have some people who estimate models, similar to the RIVM models, for example. And together we try to make sense, epidemiologically speaking, of what is happening, what is likely to happen, and using that I inform the rest of the Red Team, like what is the current situation, what are our forecasts, etc. And that feeds into the discussion that we have. Yeah.
Right, and I have to say, as someone who was reading those daily updates from the RIVM religiously during the first wave, your Twitter feed has been invaluable. Of course, I kind of don't decide how I'm feeling about stepping outside my door until it's been 3:15 and I've refreshed Twitter and learned the good or the bad news. Could we talk a little bit about some of the things that you raised? So you said you first got started with this in crunching some numbers on excess mortality. What did you find?
So basically in the beginning, of course, in the first wave, we saw really unprecedented increases in infection, hospitalizations, and also deaths. Because at some point, of course, we took measures, but like every other country, it took some time to do that. And that led to a lot of deaths in the first wave. So I think the total number between basically beginning of March and end of June ends up with 10,000 people dying of COVID. So we basically saw similar trends that we saw in other countries. First couple of weeks when the epidemic really exponentially increased, the number of deaths also exponentially increased. Then after the lockdown, effects started kicking in. That also decreased really fast in the first wave, especially. Yeah.
And now has the official COVID death count been closer to the excess death count in the sense that now everyone presumably gets tested before if they end up dying? Have you seen that change?
No, because the problem is not that people are not tested for the death count. So of course we test more, so that helps. The biggest problem is that there is no mandatory notification of infectious disease deaths to the RIVM. So hospitals, for example, or nursing homes are not obligated to notify the Public Health Institute that somebody died of COVID. And we see that the underestimation has stayed really stable, basically up until February, because we have numbers from the Central Bureau of Statistics, and they use the death certificates in combination with positive tests from the GGD, so the local public health authorities, and they counted up until February 2021, and then they counted 27,500, while the RIVM up until then counted 16,000, doing this from the top of my mind. But that factor has basically been very stable. So the idea, if people want to do a simple count, is multiply the official RIVM number by 1.7, and you'll get very close to the current real number of deaths.
And do you know how that compares to other countries, especially countries that were assumed to have done very badly, or countries that seem to have done well?
Yeah. So for example, Belgium does not underestimate deaths because they're pretty liberal in the official count.
But they overcounted, right? For sure.
Yeah. So I think they're pretty close or a bit overcounting because they were pretty liberal in the official numbers, while the RIVM has, and that makes sense to me, a stricter policy of we need a positive test, and then we need to be notified, of course. While in Belgium, especially in the beginning, they also counted people with COVID-like symptoms, so probably it's COVID, and that's a reasonable assumption, of course. If you want to make a comparison between, for example, European countries in terms of excess deaths, first, basically that's impossible. Because there are so many factors contributing to this, the official death counts are just really hard to trace. But if you ignore all that, but I just have to say it because science and nuance are important. If you ignore all that, there are countries that have done worse, such as the UK, for example, and there are countries that have done way better, such as the Scandinavian countries, with the exception of Sweden, of course.
Right. And if I understand correctly, excess deaths as a measure takes into account death, not necessarily deaths related to COVID, but deaths that would have been preventable if there hadn't been a strain on the healthcare system, right? I mean, it estimates how many more deaths than were expected for that period, right? So those people who were denied care or had their operations delayed would figure into that number.
Yes, although that's really hard to disentangle, of course.
Right.
There's two ways basically of doing this. The first one is indeed estimating excess deaths based on how many deaths would we expect if this would be a year without COVID, basically. And that you calculate based on the averages of the past few years. You take into account seasonal trends, but also life expectancy cohorts. So we're getting more older people in this population, for example. And if you mix all that together, then you get an idea of how many deaths were to be expected. And then you compare that to the actual amount of deaths. Of course, that's very crude because that's just comparing two numbers, and that doesn't give you a proper clue already about what is driving those excess deaths. And of course, in the first wave, it's pretty clear. There were no basically no other reasons than COVID that could have caused those deaths. But if we look at, for example, the second wave in January and February, that's in a period that we normally see a lot of flu deaths, for example. So then the expected number is a bit higher than that was, for example, in April in 2020. So then the excess deaths are an undercount, actually, because the models usually already take into account flu deaths, but those didn't happen this year. Well, or at least a very minimal, because it's so much easier to crush flu than COVID with the measures that we use.
Even the limited measures that we had compared to other countries. I mean, I was surprised. I was surprised by that myself, because I was nervous that I didn't get a flu shot this season, and someone told me, look, if you're taking precautions against COVID, you're not going to get the flu, and they were right. In fact,
I mean, the reproduction number of flu is so much lower than COVID. So with the measures we've used the past year, it was extremely easy to crush the flu.
Which
definitely
seems to suggest that maybe we could make a minimal effort each flu season to prevent those deaths, right?
That is one lesson I think we need to learn from this pandemic.
Okay.
Yeah.
Okay, great. So let me ask you. You said that you look at a bunch of different numbers. What numbers do you report daily, or what kinds of numbers?
Better question would be, which numbers do we not record?
Okay.
Because we try to trace basically everything there is currently in open data, or we from the RIVM, or we take it from other places. So usually we trace the number of positive tests, hospital intakes, ICU intakes, deaths, of course. We split it up for statistics in nursing homes, because they get published separately. People older than 70 plus still living at home, for example, but also the variant data, right? So the RIVM publishes the sequencing data. We use those for models of estimating prevalence of variants, for example, so the alpha or the delta now. Basically, if there is open data about it, we'll parse it and we'll publish it. Mobility data is one thing we've been keeping track of since the second wave. So how many people are using their car, how many people are driving to school, work, or time off, for example. And at some point we started parsing traffic intensity. So you can trace the amount of cars that drive on highways each day. And all of that is an indicator, of course, of our behavior and whether we are following the measures as intended. Yeah.
Right, like mobility data.
Yeah.
And what can you tell us? What do the numbers say now? What is the current picture of the Dutch pandemic?
The current picture is pretty good, I would say. I'm currently optimistic about what is happening. Obviously, I would always like it to go down faster. I'm ambitious, I would say, like that. But currently it's going very well. We have about 400 people in the hospital left. That's less than a quarter of what it was compared to the peak of the waves, of course, or even 1/6 of the last peak. Deaths are down to single digits, have been for weeks now, mostly due to vaccinations, of course. And the positive tests are also going down below 1,000 a day. So all of that is it's looking well. Yeah.
I've noticed the last few days that the positive cases seem to be hovering around 600 or 700. Do you think that this is going to stabilize there, or that it's actually going to drop further?
Tricky. Forecasting is really difficult, because it used to be pretty easy, actually. But by now, I would say it's getting more difficult because vaccinations are in play. And that just makes it more difficult. Of course, holidays starting now, so people are gonna go on holidays.
And football.
And football. So the question, of course, is whether those couple of big events, in combination with the testing policies that we have in place, in combination with the fact that there are way less infectious people than during the peaks, right? So we remember from last summer, there was this huge protest in Amsterdam, the Black Lives Matter protest. 10,000 people together, wearing masks, being outside. And basically nothing happened because there already were so few infections that if you wear masks and you stay outside and there are only a couple of tens or hundreds of infections a day, then even such big events will not cause problems. Currently, that's a bit different. I think the epidemic pressure is a bit higher than then, but in combination with the testing, I'm not sure it's actually going to lead to huge explosions currently.
Okay, so I want to follow up on two things there. The first is right now, the public can easily access self-tests, rapid tests, rapid antigen tests. These are freely available in grocery stores, drug stores. How do we know what percentage of positive tests are actually never reported because they're just happening at home? Or how many are missed because people don't know how to use those tests? Do we have any idea?
No, we don't. What we do have is the sporadic information we get through OMT advices, because they tend to report on how many tests at the GGD, so that's the official testing streets, of course, are confirmation tests of positive self-tests. So they tend to report that, but those are once every 2 weeks. And then they report on the amount, this amount of tests at the GGD was a confirmation test based on a positive self-test, for example. Basically, that's it. So we do not have a proper clue of how many people self-test. Before the big testing business got going with all the testing streets for the events, for example, we had some proxy because there were a couple of suppliers in the Netherlands of these self-tests. So when they mentioned, I'm getting increases in sales, then we knew people are testing more. But now there's just so many that based on these self-tests, we have no clue. There is a nuance, of course. We still know that a lot of people will go to the GGD test streets, and the percent positive there by now has reached 4%. That's pretty low compared to the, at some point, even 20% we were hitting. And below 5%, the WHO also mentions that you have a pretty okay view of the amount of infections that are going on. So no, we don't know how many people are doing self-tests, but at the same time, I would say we have a reasonable view of the number of infections currently taking place.
The other thing I want to ask you about, which you briefly mentioned, was Delta, because as I understand it, places that are much further along in vaccinating their populace, like Israel, the UK, parts of the United States, are starting to see increases in cases and also in hospitalizations. So given that the Netherlands has actually gone in the opposite direction and has lifted a bunch of measures, including really basic things like masking, working from home, why are you so optimistic? As I understand it, the Delta variant, it could have an reproduction number of 7, which would put it at twice as contagious as wild type. So, you know, what's the other side of this picture? What's the other forecast? Or do you have the forecast?
Well, I'm optimistic for the upcoming weeks. I'm not optimistic for the upcoming months. And that is especially due to the Delta variant. Indeed, the current estimate is that if this variant would be the first wild type variant, no immunity, no measures, then it would have an R0 of 6 or 7. That's about 2.5 times higher than the wild type variant.
Yeah.
Indeed, we're seeing in countries such as the UK, Israel, and I think especially the latter is the most problematic indication that this variant is not a variant anybody wants in their country. The difference between the UK and Israel is that the UK has been using vector vaccines such as AstraZeneca a lot. We know that those perform well for serious disease, so hospitalization and death. Yeah. But the current estimate is that protection is 60% against infection. The mRNA vaccines provide around 90%, and Israel basically has used Pfizer, which is currently, based on the current data, I think the best vaccine we have. And even in Israel, we see cases going up.
Right, and they're putting masks on school children again, something that has almost never happened in the Netherlands. So,
True.
yeah.
And I think what we can conclude is that if you have an R0 of 7, then you can calculate a rough estimate of how many people you need immunized before the pandemic is really, really over due to immunization. And the idea is that we take 1 minus 1 divided by R0. So you get 1 minus 0.14. So you need about 85% of your people, of your population immunized. The extra problem there is that works under the assumptions that vaccines are perfect. So they protect 100% against infection, which they also do not. So the current idea is that you need about 90% of your population vaccinated before you can get the pandemic fully under control purely with vaccination and immunization. I think 90% is virtually impossible because not everybody wants to be vaccinated. There's a large group of people, 18 minus, that we're not vaccinating currently. So with that variant in play, and the way we've been handling this pandemic, I'm not very optimistic for the next couple of months.
Okay, so your forecast is a summer forecast.
Yes.
Okay. Well, that is consistent with what our RIVM has said too, that they do not expect in the short term an increase in hospitalizations, because it sounds like the population that this is most going to spread in is younger people who are less likely to end up in the hospital, at least initially, with this variant. So, okay, I know you're not an epidemiologist or virologist. However, mathematically, you're saying that in order to avoid more crisis in healthcare, you need something like 85% of the population vaccinated. Does that mean that the Netherlands is going to have to reconsider the sort of reluctance to vaccinate children?
There's many ways to control a pandemic, and vaccination is just one of them. And I always think of this as the Swiss cheese model. I'm sure your listeners are familiar with it, but to shortly explain, the idea is that all measures are slices of Swiss cheese, and they have holes in them. So one slice by itself will never be effective, but if you just stack a lot of slices behind each other, the virus will have difficulty getting to the entire bank of slices, because each hole is covered by another slice. So yes, vaccinations are a great tool, but from the start, we've been saying also in the Red Team, vaccinations are not the only way out. So there's multiple things we can do. And especially with variants such as Delta, we can be pretty sure that vaccination is not necessarily the way out. There is a lot of discussion in the Netherlands about vaccinating children. And I think the discussion is not about the right thing, because it has been mostly about should we vaccinate children either for their own protection. I think both you and me could be counted under that corner, that we need to protect kids from this virus, because even though kids are less vulnerable, they are still in danger of getting serious consequences if they contract the virus. Then there's the people who would say you cannot use children to gain herd immunity, for example. What I think
isn't that what we've been doing for the last year and a half? Using children to get to herd immunity?
That would be the conclusion of some, yeah.
Okay.
But I think what is missing here is the point that we need to get the whole world vaccinated, if we want this pandemic to be over. And currently there's a scarcity in vaccines. So the question is, in a country such as ours, where we have the resources to use a whole bunch of other measures to control this pandemic, should we not submit our vaccines to COVAX, for example, so we can distribute them among countries which do not have the resources to stick to these measures? Because remember, we can handle lockdowns economically. It's not great. Nobody wants it, including me, but economically, we can handle it. In the global South, not working a day is not having food for a day. So their vaccines are a much more effective tool to control the pandemic. So how to distribute vaccines, I think is a discussion worth having, and we're not having it in this country, I think.
Right.
Yeah.
So, and also there are countries that are further behind on vaccinations that haven't had to fear about major outbreaks. Of course, places like New Zealand and even South Korea, which, Australia only recently seems to have had any worries, and they're still talking about double digits of cases, right? So if you have a containment policy or even a more aggressive mitigation policy, like in Germany, you don't apparently have this same urgency to get children vaccinated because you just don't have a lot of community spread. But the Netherlands has basically been at a high risk level for, I think, all but 3 months, which would have been last summer, if I'm correct.
Yeah.
So that it's really been, as someone who's a vulnerable person, it's really been bad weather for like almost the entire pandemic, to use that metaphor. And there's places where that certainly hasn't been. That's a good point about vaccines in other parts of the world. I have a couple of questions about things that you've talked about on Twitter before. So sometimes when you report the data, you say that there's been a storing, some kind of like computer outage or power problem. Can you talk about how often this happens and what you think is going on?
This happens. I'm trying to look for the correct qualification. Intermittently, let's use that word.
Okay.
So sometimes we've had a couple of outages in a couple of days in a row, actually, sometimes not been there for a month. There's many reasons why there's issues. First, it's IT, and IT tends to fail sometimes. It just happens. In many cases, rebooting your computer solves the trick, but that's not the case with epidemiological data, of course. Second is there's a couple of layers that the data needs to go through, right? So there is the people going to the testing street, then there's the actual labs, they need to send it to the GGD, the GGD collects it, then sends it to the RIVM, they do the cron jobs into the data sets, and they get uploaded. Sometimes there's manual errors because they happen, and then the data do not get submitted to the RIVM, and then the RIVM reports this specific GGD has had an error, or they do not report anything at all. That also has happened, and then we made a big fuss out of that on Twitter, for example. I think stuff just happens, mostly, although at some point it gets really annoying. Because after 60 months, you would expect a flawless data stream to be set up, but still we're dealing with human errors, and they will continue to happen.
One of the reasons I ask, of course, is that the media seems unusually complicit in promoting whatever the government's policy line is. And so sometimes there'll be an outage, a computer problem, and the figures will be low. And the NOS will report, only this number of cases today, and they won't put the extra information there that there was this. I don't want to sound like a conspiracist, but it certainly is helpful to have bad data every once in a while, especially if there's some controversy about measures being relaxed too fast or something like that.
It works both ways, actually. In September, so at the start of the second wave, there was a day when we've had deaths of single digits for days, but they were slowly increasing. So like 2, 2, 3, 5, 7. And then one day we had 34 out of nowhere. Mm-hmm. So people were going crazy. Like, is the epidemic rising so fast? Newspapers were with headlines like, I'm exaggerating, but everybody's dying from COVID now. And then I saw... Yeah, because of it was a really weird spike. And usually when I see weird spikes, that triggers there's a data problem. So we started building these little trackers that would take a note of when did these deaths actually happen.
Yeah.
And that specific day, there were 21 deaths from one GGD who started cleaning the archives. And they basically found 21 cases of people who had died already, but did not submit yet to the RIVM. So basically, these 21 deaths were from April and May or something. These people still died, which is horrible, but in the context of understanding what was happening epidemiologically, that data didn't make sense anymore. So when we subtracted those, we got to a number that was realistic. And then I started sending messages to newspapers like, fix your headlines, because you don't have to shout like there's 34 deaths, it's going nuts. Now, I mean, there was a problem, there was a huge problem, but that wrong interpretation of the data, because checking the real details of the data, it happens both ways. I think what the biggest problem is that we could use some more data journalists in general. That tends to help, because the ones I speak to, the data journalists, they usually first check these kinds of things before they make headlines. And the rest just reports the data as it gets in, of course.
Yeah, I mean, I spoke with a researcher who looks at is a historian of science, Chris Maines, a few episodes ago. And they looked at how the contact tracing data from the heyday has been a little bit strange, and it really suggested the need for closer scrutiny of those numbers and what's behind them. Well, let's talk a little bit about your own academic background. As I understand it, you're in the final year of your PhD research. Sure. Congratulations. And you work you research an area called organization studies. What is organization studies, and what are you researching?
This is always the trickiest part to explain. Summarizing, we study the human side of business. So basically, we're trained as a combination of organizational psychologists and sociologists. And at the department that I studied and currently work at as a PhD candidate and lecturer, we mainly focus on interaction and collaboration between people and organizations. So we try to understand what the drivers are for effective teams, for effective inter-organizational collaboration, how to produce innovative outcomes for organizations, for example. So we have a multi-layered group of people that basically study teams, organizations, and collaborations between organizations. We call those networks, of course. That's the big picture. What I do here is I focus on a field called the behavioral theory of the firm and behavioral strategy. And there we try to merge insights from psychology and sociology into strategic management views. So strategic management has had this very rational idea of people are fully informed when they make decisions. The same goes for organizations. We take all alternative options into account, and then we choose the one with the best expected value. Obviously, that's totally nonsensical, because people do not have the computing power to make fully informed and rational decisions. So what people do, and I'm using this long build-up because it gets back into the pandemic issues. What people do is we use heuristics to make decisions. So we use shortcuts based on our own experience, based on what we observe from others. So that's vicarious learning. We use reference points. So I always tell my students when I explain this, like, if you always score a 7 on your exams and then suddenly you score a 4, that's a trigger to think about what went wrong, right? I drank too much beer the night for the exam. I didn't study enough. I have a bad teacher. It happens. But if you always score a 7 and then you score a 7.3, then usually you do not do anything, because that just falls in line with what you expected. Even though you might have done better. So on this specific course, probably you could have gotten a 9 if you would have done better. You see a 7.3, and then the trigger is, that's what I usually get, so all is fine. So this is how people think about performance, generally speaking. And we see the same type of behavior for organizations. And my dissertation and general research is about trying to understand how people form performance targets. So where do these targets that we aim for as organizations, as people, actually come from? And what happens if you fail to achieve the set targets as an organization?
So what are the managers of this crisis, the outbreak management team, Rutte's cabinet, what are the heuristics that they're using, as far as you can tell?
Tricky. That is from a distance, that is really tricky. I think what they've been banking on is experience in the beginning. So at the beginning, I think we were banking on flu protocols, for example. That changed as soon as we saw the impact, I think in the Netherlands, that it escalated so fast that that didn't work anymore, of course. But what the interesting thing about these heuristics is that they are insanely hard to battle if necessary. And one example I've given in other interviews is that at some point we had the contact tracing system crashed completely because we didn't have enough of them. We understood we needed more, and we started to train new contact tracers in April and May. Then the epidemic in the first wave went down fast. And then I think somewhere mid-May, I was calling with a friend, and I texted him after our conversation. I was like, I'll make one forecast. I've made many after, but back then I didn't know I was going to do that. And I said, my forecast is this: the infection rate will go down in June. End of June, somebody will announce, we'll decrease the amount of contact tracers because the epidemic is basically over. We'll go on holidays, we'll import infections from abroad. End of July, it will go up again. And then the beginning of August, somebody will show up on TV and say, we did not see this coming. He texted me end of July, like, your prediction was almost perfect. The only difference is there was a person on TV already end of July saying we did not see this coming, because we didn't have enough contact tracers because we downscaled all of them. And he said, how did you predict this? And I was like, this is what I'm talking about when I'm talking about heuristics, because we've seen the contact tracing system crash big time in March. Biggest pandemic anybody on this planet has been in during their life, basically. And then the reasoning in May is it's going down, and therefore we can scale down the contact tracers instead of thinking probably it's going to go up again. So we need to maintain the system at this a really high level and probably train some more because of a second wave, for example. And this is the type of heuristic, even if you get this brutal feedback that we got in the first wave, like this system doesn't work, this way of decision-making does not work, we still keep on doing that. And that's what we have seen here. Yeah. I think over time, the effectiveness of learning is not at the level I would like it to be, as somebody who studies decision-making and organizational learning. Yeah.
Yeah. It's interesting that you mentioned the flu, because that's also what I thought of when I thought of what heuristic they might have been applying. But of course, from where I'm sitting, the Netherlands, like many Northern European countries, doesn't have a very aggressive seasonal flu plan compared to, say, US and UK, where they try to vaccinate up to 70% of the population. So I thought, well, if that's the model you're using, you won't necessarily protect enough of the populace with that plan. But there seems to be another kind of thing we're not talking about here, which is that Rutte did announce in his famous speech back when in March of last year, he did announce that we were going to pursue a controlled spread, which has sometimes been called the herd immunity policy. Do you think that that is the framework that these managers are using? Is it primarily about ICU capacity and healthcare capacity, or do you think that there's something else going on?
I think that's one of the biggest questions during this entire pandemic, especially for the Netherlands. Based on the decision making that I have seen, there is no other conclusion to make that in this pandemic, the main performance indicator that we've been using to control the pandemic has been hospitalizations. In case hospitalizations do not go up, then there's no problem in this country. That's a bit, of course, making it a very exaggerated statement, but I think that's pretty accurate. In a theoretical alternative universe, if we would have seen 10,000 infections a day but no hospitalizations, then nobody would do something, because healthcare can handle. I mean, that's even one of the official pillars of this policy, is protecting the vulnerable, keeping a good view of the epidemic, and making sure that healthcare does not get overloaded. So there is no pillar that says we need to get infections down to a low level, for example. That is not an official pillar. So yes, the way we've been looking at this pandemic here, at least from the politician's view, is if hospitals do not get overloaded, there is no issue.
Right, but that only means overloaded in the short term, right? Because of course now we have 140,000 operations that were delayed or canceled. That the at best estimate is 2 years to catch up with all of those operations. Of course, people that are dealing with life-threatening illnesses may not actually see that treatment. So it's sort of like what you said about the forecast for right now. In the short term, it looks like we're not going to have overloaded hospitals, but we're going to pay the bill later, it sounds like.
Definitely.
Yeah.
Yeah. I mean, we're already paying the bill currently. There was an article last week that said that during, I think, the first and second wave, there were a couple of hundreds of deaths caused because these people did not have access to healthcare because there was basically no space due to all the COVID patients. So yes, in the short, it's very much all of the response are very much focused on the short term, I believe.
You also advised the health department on the dashboard. Can you talk a little bit about this and what you do for them and how that was put together?
Yeah, so at some point last July, I got an email from the health department saying we need experts for this data and dashboard panel. I figured I'm an expert because I tweet numbers, apparently. But of course, you're honored and you accept the invitation because you get the advice. The main department of health during a pandemic. It's an honor in a way. So there was a panel basically of people, of data journalists, data experts, people who've been working with Corona data, user experience experts, for example. And then basically they build a first version of the dashboard and they were saying like, okay, this is the one we have. What do we need to do to improve it? So we were advising, I think that was July, and then we were already in the red team with Bert Slachter, the complexity expert, and Edwin also. Like you need to get to a regional dashboard. You need to connect the indicators such as infections and hospital intakes with explicit measures. So basically they automatically kick in once you reach certain levels, because that provides clarity to people, and the one thing people need during a crisis is clarity. So tell me what to do and tell me how to do it, and I will do these things. So we've been advising that. At some point, there was a regional dashboard, and the link between indicators and measures, that basically never happened. And that's when we got the second wave at some point, because there was not a lot of action taken, and then we just reverted back to national measures, which is lockdown. Yeah.
There also wasn't just that the signal values triggering measures didn't happen. It's that, if I recall correctly, especially in the early days, they simply changed the signal values on the dashboard when we started exceeding the limits that were first set, right?
No, that's been the discussion. What they did, they changed the color scaling. But the official signal values never changed, but that didn't actually matter because they were never used anyhow.
Right.
So it was a coloring thing, but I've been surprised by that part. But the problem was we've never used the signal values because at some point when we reached them, we either changed them policy-wise, or we came up with other reasons why we shouldn't use them at that point.
Right. Or like, I mean, I think most of the relaxations were announced when all 25 safety regions were still at the highest risk level. So, what good is it having those values if you're not going to make them linked somehow meaningfully to a change in policy?
Yeah, I mean, at some point, on the dashboard, they used the GGD hospital data, and that suffers from the same problem as the death data, which is there is no obligation to report hospitalizations of infectious diseases. So the GGD has a huge undercount of the actual hospital intake. So we look to NICE, which is the National Intensive Care Registration System. And they actually allow doctors to manually put it in. So that has been a much more accurate number. So then at some point in December or September, we were screaming loudly, like all the signal values have been passed. And then other people, I've had discussion with Mark Bonte, for example, back then, like September 2020, was like, I'm looking at the dashboard. That's not true. I'm like, yeah, but the dashboard data is problematic. You have to look at this other data.
Right.
So there were all these types of discussions back then based on the signal values, the data, and we've just been screaming, this is an epidemic, there's
Right.
exponential growth, you need to do stuff now, regardless of signal values. Yeah.
And I recall there was a day where you, other members of the Red Team and other independent researchers actually just didn't report any data, where you had a data blackout day.
Yeah, we
a protest. Yeah.
We did that twice. So there was the December 2020 was that day when Rutte during the press conference literally said the numbers are going up, but we're not going to do anything. And then we just reached the point. So one of my colleagues in the data team, so to speak, was like, but what is then the use of publishing the numbers, guys? If even if it's going worse, they're not going to do anything, then there's no sense. So we had a conversation and we were like, let's do a protest day to send a signal, which then ended up in the news. So that was pretty funny. And then 2 months ago, the cabinet announced, like, we're not going to look at infection numbers again. Hospitalizations is the only thing that matters because of vaccination. And then we did replaced all the numbers by saying not relevant with every number there was. So that was the first one was really well received. The second one mostly well received, and other people were like, but I want the numbers, so can I get the numbers now?
Yeah, like me checking the weather before I leave the house.
And then people are like, you are now our national COVID numbers service, so I demand numbers. And I was like, then you can go to the dashboard.
I have an observation about this, which is that I mean, you study organizational psychology. You look at, one of the things you looked at is heuristics. Like I to the extent that I still have an academic career, I'm a humanities person, right? And so I looked at the sort of metaphors of pandemic response, and I was very struck by things like roadmap, dashboard, right? Which conceptualize the disease and the pandemic as a sort of moving vehicle that we can't stop, but that we can only adjust the speed for. And it occurs to me that the whole framing of this suggests that we can't even conceptualize, say, what happened in Vietnam or in New Zealand, where they say, no, there is no dashboard because this isn't moving through our population. And it really seems like this framing simply made the discussion about how fast that vehicle should be going. It's not just the dashboard, but it's also, you probably remember this simulation that was commissioned by the Dutch government from something called Gupta strategists, where they actually had they conceptualized the pandemic as a train, right? And they said, this is, based on the speed, by which we mean how little public health measures you put in place, how quickly you'll arrive at your destination, right? Which seemed to really accept the logic of herd immunity to some degree. Like, we have to get to this destination. Are we going to go fast or are we going to go slow? What do you think about this? Do you think if we had had a different metaphor, a different way of visualizing this, that we would have approached it differently?
You're asking a numbers guy whether we should have used different metaphors. So that's a difficult question.
If we didn't have a dashboard, if we said, you know what, we're not in a moving car. Actually, what we've realized is we need to stop the car. Because when they did that in places that contained or at least aggressively mitigated, like Germany, people went back to somewhat normal lives with relatively little risk. So this thing got us, and myself included, obsessed with daily numbers. How fast is it going? And I've got to do that all over again right now. I'm still a few days away from my second shot, which means I don't have my 90% Pfizer immunity for 3 more weeks, right? And so I've got to like look at the figures and say, well, is it safe for me to go to the doctor's office where nobody wears a mask? Is it safe for me to sit on the terrace with my friends who I haven't seen in a year? If we hadn't have looked at this as an issue of like how fast we go, of what the proper level of virus, floating around at any one time, if we had conceptualized it as like a car that wasn't moving, would that have made a difference? Maybe I'm not. I don't know. Maybe you don't have an answer for this. It's fine.
Yeah. I'm not sure if the metaphors, but many discussions I've had, and I think the 2 protests, they allow some view, especially the second one, because people were like, but I need the numbers. And my response to all those people has been, why do you need the numbers? Because 1, does it make a difference on a policy level? No. 2, does it make a difference on an individual level of how you should go about and which type of behavior you should show at this moment in the pandemic? No. So the numbers have 0 value in a way. People just want to know. And as you mentioned, people get addicted. So people were really mad. The second time we had protests, they were like, but I have a right to know the numbers. And then I was like, well, you did not pay me. So go to the freaking dashboard. I'm just making a policy statement here.
Yeah.
And I've had the discussion with many
your PhD,
people.
by the way. You got other things to do.
Definitely. But I've had the discussion with many people. I think numbers, 1, are a partial reflection of reality. They only tell a very little part of the story, but they're very easy to look to, right? So it's really difficult for people to hear real impact stories of people who've been hit by COVID, people who've been hit by the measures economically, for example. It's just easier to see, okay, there are 18 people that have died of COVID today. And then you go on with life. But those items, frontberichten, so stories from the front, right? We had in the first wave, for example. I think that is much more impactful. But by this point, I'm now that dude that publishes the numbers, so I'll keep on doing it.
I mean, the numbers are necessary, right? And especially when you can't often trust or depend on the numbers coming from the state. It's just, I looked to use an example, Ben Coates, who's a British expat here who comments on corona policy, he was quite critical by, I think, his standards during the pandemic. And then he recently tweeted that he was supportive of relaxing some of the measures because he said something like only 5 people a day are dying. And I thought, this is the trap. This is the trap, is that you have a number in your head that's like an acceptable number of dead. And it's worth noting that 0 was the acceptable number in many countries, and we kind of lost sight of that right away.
I think what many people even forgot is that within the realm of exponential growth, there is basically over time no difference between everything above 1 and infinity, because it will grow. Same for below 1, because then, yes, it's decreasing, but at some point, if you don't do anything, it's going up again. There is one number that actually is different, and it is 0. Because New Zealand, for example, for a long time, they had an R0 or an R effective of 0, which literally means there is no more cases. So that is mathematically even a whole different universe. And I think we've been very focused. And I think that's where, for me, the roadmap and the dashboard and all the metaphors that are driving me crazy in the press conferences, it's an illusion of control in a way. Like and I think that was most clear in the start of the second wave, when the government decided to close bars at 9 p.m. Because closing bars at 9 p.m. would help. Well, maybe. And then the next one, that was the mid-October package, was they actually said we're aiming for an R of 0.9. So the model said, if you do this, you'll get an R of 0.9. And then the cabinet was like, we'll do this because this is not hurting the economy so much. This was confirmed by Minister De Jonge in the podcast that I have myself. Like, we need to balance economy and healthcare. And so that one was going to control the pandemic, but not hurt the economy too much. Obviously, that was never going to work, because everybody who understands exponential growth and how a virus works can tell you that you cannot take precise measures and then a model tells you the R will be 0.9 and then it's actually going to be 0.9 because you're dealing with a virus and human beings. So that was some weird illusion of control that they had, and then they had to learn again, because there was the second wave already, that viruses do not work like that. And that has just surprised me. And that links back to your metaphor of the car, like we're driving, we have some control, we can increase the speed, decrease the speed. You can't.
Well, the other thing I wondered about, because I was also not a huge fan of the curfew, which was like 3 months of, don't leave your house after, well, first it was 10 or 9 and then it was 10. And I wondered why we opted for curfew over a better mask policy. Like, for instance, as I'm sure you know, the masking policy in the Netherlands, such as it is, we're getting rid of it mostly on Sunday or Saturday. Such as it is, it doesn't really do much to stop aerosols, because you can take off a mask once you sit down at your job behind a desk, or if you're the cashier somewhere, you just get behind a plexiglass plate. And it seems strange to me, because I would guess that we could have had more people on the side of the mitigation measures if we had not done something like curfew, but instead said, hey, everyone needs to wear an FFP2 every time they're indoors. It seems like that would have made a much bigger difference and wouldn't have turned people against, especially certain people, against the pandemic in quite the same way. Why do you think they chose something that on the face of it was much more repressive than, than simply just wearing a mask or.
I think, again, because of there's a form of linearity in the decision making. So I mentioned with other people, economists and others who work on decision making and uncertainty, that if I am able to predict the policy decisions, then probably they are bad, because then they are linear decisions. Okay. And what you need in a pandemic is decisions that encapsulate complexity, the uncertainty, the exponential growth. So that's usually been my slogan. If I am able to predict it, it's probably bad. As a person who studies decision making, and then I think, for example, such as masks is that type of asymmetric measure, right? So there are virtually no costs. If masks do not work, the only cost is that we've been looking crazy for a year because we wore masks. Well, that is zero cost for me. But the upside could be huge. Same goes for ventilation. I've actually had this discussion with the Department of Health in August, so with the Secretary General, when we had a conversation as the Red Team with Minister de Jonge and also the Secretary General, so that's the highest civil servant. He was like, what do you think of other measures? And I was like, ventilation, it's important. And he was like, are you also one of those ventilation people? I was like, no, I'm not necessarily one of those ventilation people, but I'm going to explain to you why this is a smart decision. And I said, the air quality in my current office, you are invited to work in my office, but it's the worst. I'm exaggerating, of course, to make a point. Yeah. Improving the quality of ventilation and air quality in my office is going to be effective for, decades, for my productivity, for my well-being. I said, if then as an extra advantage, it also helps to control COVID, then it is a very effective measure. If it doesn't help to control COVID, at least my productivity and well-being for the upcoming decades will be better because the air quality in my office is better. So there is no reason to not do this now. And this way of thinking about upsides, downsides, asymmetry of risks, etc. That's not the way current, I think, majority democratic decision making tends to work, because if you make a mistake, then there's huge political costs. And I think New Zealand, for example, Arden has been very clear. Like I have one value that is driving my decision making, which is public health, and I will not accept deaths from this virus from the beginning. Then it's very clear where you're coming from. It's also very hard to negotiate. And it worked out very well. Could have been very different, of course. But she made the smart decision, and now she's that person that everybody wants to be their prime minister,
But
basically.
it also seems the case that that the Netherlands policy, the policy that we're seeing, setting aside the sort of conspiracy assumption that actually everything is just designed to promote herd immunity. Like let's assume there's a good faith effort to mitigate. It seems like it's based on a set of scientific assumptions that the rest of the international scientific community doesn't share, right? So for instance, RAVM has been quite insistent that the virus spreads through fomites and through droplets, right? And reluctantly changed some of the information around aerosols. And so that seems to be why we don't have a focus on masks and ventilation. Also, of course, various members of the government have sort of made sort of racist remarks about masks, right? That they're worn in Asian countries, and well, Asian countries aren't able to. So there do seem to be a set of assumptions then that get baked into the policy there, that all seem to come from Van Dissel, because Rutte doesn't seem to have a lot of opinions about how diseases spread. Independent opinions, right? I just want to ask you one more question about, so you've, because you have a podcast, Signal Board, right? You've had an opportunity to talk to some of these people. Is there anything that our English language listeners or international listeners should know about your interviews with de Jong and Marion Koopmans and some of these people who, to me, feel like they're on another planet and not anyone I can actually ask a question to?
I think there's a couple of things we have to discuss here. It's multi-layered. So there is, of course, the outbreak management team. We've had multiple members of them. So Mark Gonte, who's a microbiologist and an epidemiologist on the show. Marion Koopmans, our I would say main virologist currently in a pandemic. 2 weeks ago, and then we had the Minister de Jonge, so the one, basically the chief responder in this outbreak on the show. And in connection to what you mentioned earlier about aerosols and masking, is that the position of the RIVM, and explicitly because we've had a meeting with Jaap van Dissel, for example, as the red team, like back in August, September, has been, if the science is clear, then there will be implications for our advice, right? So the science on masks, of course, there is no way to do a randomized clinical trial where you take like 2 islands and then one you allow to wear masks, the other one you should show the exact same behavior, and then you drop a virus in and then you see what, right? That would be the perfect evidence, but that's just not realistic. So you need to understand from indirect evidence whether they work. My conclusion, and with the red team, and I think basically a lot of people and scientists all over the world, is there's enough indirect evidence that masks have an effective, are an effective way to control the spread of this virus in certain situations. But it hasn't been shown with randomized clinical trials. But the AVM is more, I think, conservative institute in saying, like, if it hasn't been really clear from the evidence, then we also cannot say that people should do this.
Okay, but I want to stop there for a second. As far as I know, and I'm a little bit of a nerd on this, but I'm also not a scientist, there has been no evidence of fomite transmission, and yet there's unceasing messaging around wash your hands, which is always a good idea. I think the Dutch should wash their hands as much as possible. You know, there's hand sanitizer whenever you walk in. So all the bars and nightclubs are going to reopen this weekend, and they're all going to be offering people hand sanitizer. But not a single person is going to know anything about aerosol transmission. And we have no evidence on fomites, and very little evidence even of droplet transmission of this virus. In fact, it does seem like there has been a paradigm shift in our understanding of the way respiratory illnesses are spread, right? But this message is not coming from our health authorities. And were they even open to this possibility when you talked to Koopmans and Bonta? Or, I mean, do they know that this is happening, that there's a whole discussion about
I mean, I'm convinced they are aware of the discussion.
right, because they must be around international colleagues who are like, oh yeah,
and they're on Twitter.
Yeah.
Many of us are sending things to them like, "Did you read this?" etc. So yes, they are. And we didn't discuss transmission routes either with Koopmans or Bonte because
Yeah.
they've been discussed so much that we
okay.
didn't want to do that with them. But we've mostly focused on the strategy, like what is the Dutch strategy and is that an effective strategy? But I just wanted to make that statement. Like, I think the RIVM has been a very conservative, like if there's no explicit evidence, then we cannot base our advice on that.
But that's what I'm saying is there's no explicit evidence for fomites or droplets.
No, I think in the beginning,
most of the evidence is for aerosol.
I'm not an expert on transmission routes, so I can't either support or debunk aerosol claims. As far as my understanding goes, aerosols are an important transmission route. Whether they are the most important, whether fomites have a 0% chance of transmitting. Usually I'm in the ballpark of, let's assume they have some influence, and any influence we can kill, let's do it.
Like I said, keep washing your hands. But
in general, because Dutch people are bad hand washers before the pandemic. So I hope that's one thing we can incorporate into the future. Keep on washing your hands, people. So getting back to the point, the problem was that politics also has a responsibility to say, so the advice is unclear or the science is unclear, we're still going to make a decision anyhow. So politics, I mean, in Germany, they've been watching the same science, and they, from the first wave onwards, were like, wear masks in elderly homes. In Berlin, you will not get in anywhere without FP2, for example. By now, I think the evidence is pretty clear, but even back then, the Germans were like, the science is not super clear, but we're still going to do it because it just makes sense.
Precautionary principle.
Yeah. And I think in the beginning here, what Rutte has explicitly said is the advice from the outbreak management team is holy. That's a literal translation. And basically, by doing that, he put the scientists on the chairs of the decision makers. And that's a huge problem because then you're making scientists responsible for politics.
Right.
I think in that case, people become more careful. The politicians can hide behind the science, which is not what science is for. Politicians hiding behind evidence that is constantly being updated, which we've seen during this pandemic. So now to your question, I think with our discussions, in our discussions with scientists, what I've seen is that tendency, like looking at all the evidence being combined. I think this was the best. I think Mark Bonte was pretty clear. He was like, if I look at everything, I think mitigation is the best. We've had the discussion. Our podcast is not a debate podcast, so we're more of we want to get the perspective of our guests to our listeners in the best way possible. I disagree with many of the guests on the podcast, but that's no problem because I'm just interested in hearing people's views, and I think the listeners care too. Same with Marion Koopmans. We've had that same discussion. She pointed out interesting things like we need to get an OMT behavior. So our outbreak management team is basically a biomedical advice team. The behavioral component has been lacking too much. At some point, we got the behavioral unit at the RIVM, which drafts a beautiful advice that I, at some point during the podcast, mentioned we should replace the advice from the OMT with the advice from the behavioral unit. And we'll be out of the pandemic in 3 months. Of course, exaggerating a bit. And then I even proposed that to Koopmans, like, I think we should do this. What do you think about that? She disagreed, obviously. But at least it was a fun discussion. And then with the Jonge, I think that was interesting because science is science and you can debate science, but policy is about values and smart decision making. And with the Jonge, so he's a politician, obviously, and he's very good at being a politician. I think I'm safe to say that. So he was defending the strategy fiercely, And I think the most noteworthy moment was when we were discussing the second wave and the start, and he admitted we should have intervened earlier, which was interesting because the official cabinet policy has always been that they've intervened early enough, but they should have intervened stronger, right? So we did something end of September, but we didn't do enough. And he actually said on the podcast, we should have done something earlier, which was totally new because they've been very consistent in saying we've started early enough, we should have done more. So that was weird. And then we continued on that line. And he started on zero COVID himself. I think there was strategy. And then saying like, there's also people who are in favor of containment, zero COVID. But I think that type of policy would have been all crushing on society, and you would have left entrepreneurs out in the cold. Because you just close down businesses. And then my response to that was, but what is the difference with the current strategy if that is your conclusion? Like if your conclusion is containment leads to strong policy, closing down mobility, which includes closing shops, hurting entrepreneurs, there is no difference with your current strategy because the bars have been freaking closed for 6 months. And we've had 30,000 deaths. So how can you say that this strategy works? Because the only difference is that we have more deaths now, but the bars have still been closed for 6 months. He had a hard time formulating a response. And I think in the end, he mentioned something like, yeah, but then they would have been closed longer, right? So now at least they've had freedom for 1 month after the summer, and then we closed them off anyhow. I'm not sure that that's the most optimal response to my, of course, question that was trying to pressure him a bit.
This is why he's a politician.
So what can
their job is to be slippery.
What can the listeners learn? I think after all this is done and over, and I'm not sure when that is, we'll get that parliamentary inquiry at some point, and I think we need to seriously revamp the way we manage pandemics. And especially review the strategy. As you mentioned, there's of course a lot of discussion about, is herd immunity intentional? Is it about, we're not, right? So the UK, I'm not sure if you've seen those interviews with Dominic Cummings. I mean, that was mind blowing, but there they had that explicit, like, we'll do like chicken pox parties and stuff. I'm not sure whether such conversations happened here as well, but in the end, the question is, does it really matter? Because the policy has been, it's about letting it go until hospital intakes are rising enough, and that in the end that leads to the same problem.
This is exactly what Amrish Baiju said when I asked him. I said, is it deliberate policy of herd immunity, or is it some sort of incompetent mitigation? And he says it can be both. And I think that's probably a realistic way to look at organizations and dysfunctional ones, which is, I know, something that you are interested in.
And we haven't even coordinated this response, Amrish and me.
Well, no, I mean, it's also what I have to observe. And I also think, like, you could spin that the other way too, which is, while the UK explicitly backed away from herd immunity, while the Netherlands leaned into it, the results were very much the same, because that thinking was still there. So the UK did basically operationalized the logic of herd immunity in a lot of ways, but left a lot of room for complaint. Whereas, unfortunately, I think in the Netherlands, public response has been pretty muted to the herd immunity plan or strategy, if it was one. I want to ask you one final question. I know that you're almost done with your PhD, and it looks like we, even in the best case, are going to have an uncertain outlook for the fall and the winter. Are you going to be our numbers guy in the fall and winter? You think you're going to continue doing this?
I mean, it's people think it's a lot of work, but by now it's so scripted that it's actually 5 seconds of work if it's functional. So if there's a storing or something else, then it's actually work. So yeah, I'm going to keep on So what I'm intending to do is at least keep on doing the numbers until everybody who wants to is fully vaccinated. So that's August, September. And by then I'll look at the numbers. If it's rising again, I'll keep on doing it. If the pandemic is over, which is extremely unlikely, then I'll stop publishing the numbers. But yeah, that's a decision I'm postponing until everybody's fully vaccinated. By then I'll review whether people should go to the dashboard instead of my Twitter account. Yeah.
Marino, thank you very much for talking with me today, and thank you for all of your work with the Red Team.
Thank you for having me over.
That concludes my conversation with Marino van Zelst, which was recorded on June 24th of 2021. I want to thank Marino for joining me again today, and I want to thank you for listening to this podcast. If you'd like to follow Marino, if you're not already doing so, he's on Twitter at mzelst, M-Z-E-L-S-T. And if you'd like to follow the Red Team, they are at C19 Red Team on Twitter, at C19 Red Team. Until next time, this is Matt Cornell, and you've been listening to Breaking the Waves.